planning, the most important aspect is the digital wax up. So really, we talked about this last time when we did the dentures. It's really the same thing. That's where we start. You start with the case. You have the patient's photos up on your screen, and then you're opening up the case, and avoid that temptation to start grabbing implants and dragging implants into the bone. Like, stop, postpone. Put the teeth in there first, and say, okay, where do I want this final restoration to be? And then you'll get an idea of, whoa, geez, my teeth are impinging right on the bone. Like, I'm gonna have to get that bone out of the way. Or, man, where the teeth are, there's just really no bone there. Or, as you're thinking that tooth, prosthetically driven dentistry. So we're driving the tooth into position, not just the implant. And I do this a lot of times, even on single units, especially like a distal extension case where they have no teeth back there to reference, and they're just hitting up here, and you want to put some teeth in there. I'll still drag and put some teeth in the back there in occlusion with their upper teeth digitally. And then when you put your implants in, you know where they need to be. So that's, anywhere from single tooth dentistry to full arch dentistry especially, start with that wax up digitally. All right, anybody have any questions about the wax ups? Anybody stuck with any digital wax ups and stuff? I know we kind of did that a little bit last time. Any questions on that? Or?
When you have like a full arch or a half an arch, you'll just go to the denture module and pull the whole thing over.
Yep.
I'll start with a whole chunk of them.
Yep.
At one time.
Yep. Exactly.
Crown and bridge.
Yes. And then, so the big thing, the big difference between starting in the denture module and the crown and bridge module is the denture module gives you that tooth chain function. So if you go to the crown and bridge module and you go add tooth, you could select a whole arch and you can drag a whole arch in there just like you can with the denture module. But now when you go to move the teeth, they're all unlinked. Like, you start moving a tooth and nothing is connected. You got to go move every single tooth, individually, instead of like taking a chain of teeth and just kind of stringing it over the arch and bending that string, or that, you're changing the curve, and they're all stuck together. So that's the beauty of the denture module. So think denture module is like the global positioning for an arch of teeth, and the crown and bridge is more your fine tooth, individual tooth movements. So, you may start in the denture module and you may finish in the crown and bridge just to fine tune. And the cool thing is, when you get this wax up done and you have the teeth in the case, in the Blue Sky case, and you've looked at the photos and you've seen, okay, I want to change this and change the occlusal plane this way. You get your teeth in there, you lock them all, and now that's set for the case, right? You're not going back and changing the teeth, that's set. And then you can, your implants then get planned within those confines. And then, the advanced stuff is where you actually then go and print those teeth into some sort of temporary that you might eventually, transition that patient towards. So those teeth are locked and set for the case. And they determine the restorative space too. So, you've got your teeth in there, and now we want to say, okay, occlusal plane, how much restorative space do I want from that? And that's where you control your implant depth. So if you want 15 millimeters of restorative space, you got your occlusal plane of your digital wax up. And that might have nothing to do with their current teeth. Their current teeth might be way below or way above that, but your digital wax up is where your restorative space is driven. So your 15 millimeters or whatever you end up choosing from that is right where your implant platforms are all going to be. Yes?
So that made me think about how you take the scan of the patient to begin with.
Correct.
Occlusion or open occlusion.
Yeah, it's a really good point. I've got a really good example of that in like a couple slides that I'm going to show exactly how I do that too, because you're right. You're thinking about your future vertical when you're taking records, so that when you do your wax up, it's accounting for that future vertical. So yeah, that's a really good point, because if you just scan them in their current bite and they needed to be opened up because of collapse, you'd have to then arbitrarily guess on that. Yeah, so your digital wax up has to take into that future vertical consideration. And I'll show a good picture of that in just a sec. So the photos, the face scan, and then just what he's talking about, your intraoral scans at the correct VDO. So on that records day, when you're taking your records, you've got to start thinking VDO. I mean, the patient's going to go through a temporary, so you can change that. But if you don't lock in that VDO at the scan of the patient, what you load into the case isn't even the right VDO. So now you'd have to do a wax up based on like a guess VDO, and you might have to digitally open them up, which we don't like to do. And anytime you digitally open up the mandible, it works, but you're based off some unknown hinge of where that condyle is. So you lose that accuracy versus like literally scanning their bite at the VDO that you want. And so face scanning, we did that last time. I have LaToya's case that loaded on all the computers with everything stitched, face scan in there, so we can start thinking about that stuff. So just like we talked about, you got your digital wax up with your occlusal plane, and if you want 15 millimeters, you're going to put your implants right at 15 millimeters from that occlusal edge, occlusal plane, occlusal table. And then you're going to make sure your access to your implants come out where you want them. So the posterior teeth, it's generally right out the occlusal table, just like a regular tooth. And then in the anterior, just lingual to those front teeth. And like we talked about before, what are most oral surgeons doing? They're just over-lingualizing. Because as long as they're lingual to those front teeth, that general dentist can't really say anything about it. And then what you end up with is like chunky, thick hybrids where the screw is way back, in the palate, and then the teeth are way forward because they had no idea where the future teeth were going to be. They just know they need to be lingual to some arbitrary position to get the case done. And then we utilize angled multi-unit abutments. We'll talk about that. When we need to lingualize more or when we need to avoid sinuses and nerves. So we've got our implants placed now. So we got our occlusal plane. We've got our implant platforms at some given restorative space distance. And then we want our bone to end up at some depth below or above the platforms of the implant. So if you like your implants to end up a millimeter, subcrustal, you'd want your bone to end up 1 millimeter past your implant position. So you think, okay, occlusal plane, 15 millimeters from that, you've got your implant platforms, and a millimeter below that, you've got your bone level. So you're just thinking like, how am I setting up these different levels and heights of everything? And then if you plan those implants where they need to be and they're way subcrustal and they're like way deep in the bone, now you're thinking, okay, I'm going to have to reduce some bone. If you're going to have to reduce a lot of bone, 3+, sometimes you can use a bone reduction guide if you want to be really accurate. You can build a guide to snap on and actually take your burr, whatever your burr of choice is, and go right across the plane of that bone reduction guide if you really want to get it right where it's at. It's also not too difficult. I've kind of simplified things a little bit where, you place those implants and then you go back and you just go to the case and you say, okay, here's my implant. And you just start leveling bone down right to where you like your implants as far as depth in bone. So it's not too hard on simple cases to just place those implants all, traditionally, and then go back and just start taking down your bone until your implants are at the proper depth under the bone. So that's doable. You don't have to guide every little aspect all the time.